Shores College and did a doctor of physical therapy from Des Moines University. His specialties include a wide range of musculoskeletal conditions and post-surgical interventions. Some of you have heard his name within the Iowa EDS community. Patients from the Des Moines area are frequently referred to him from the University of Iowa Genetics. His treatments have helped individuals of all ages, wide range of age groups that he works with, and he's able to return them to physically active lifestyles, which is really something that we all look forward to. And so Erich should be able to give us some ideas today on how to reach that goal. He loves making connections with people and exploring ways to motivate and treat on an individual basis. He spent much of his life in West Des Moines. He's married with 2 children. His wife is a pediatrician at Unity Point, and he currently practices out of West Des Moines Physical Therapy.
Thank you, Deb. It's a pleasure to be here today. I'm happy to be the guinea pig of the group. It's been kind of a journey for me in the last few years too, because it was probably back in 2011 that I saw my first case that I was able to recognize and the patient didn't have a diagnosis, had no idea what was going on, doctors had no idea, and pulled back on some of the training that I had back at One University, and kind of the light bulb went off, and I was like, I found it very interesting, and I think the doctor was appreciative as well that we brought that to her attention, and so I think that that's part of the reason that treating people with Ehlers-Danlos syndrome is interesting to me. Is a lot of times for years and years they've gone through various doctors, various forms of treatment, sometimes frequently unsuccessfully, and so finally when we can kind of get everything in the right direction and get things working more efficiently, that's something that I get excited about, and that's why I enjoy treating this population. I'd like to thank Chris and Deb and Jerry for having me today, and I think that this group is awesome. That hopefully you find a lot of growth and are able to help the local population with Ehlers-Danlos syndrome. So I'll have you flip the slide. First slide, some of you may recognize this. Zebra is kind of the identifying animal that is that the Ehlers-Danlos Society has used to help bring awareness. In the 1940s, Dr. Theodore Woodward from the University of Maryland instructed his medical interns that when you hear hoofbeats, that you should take horses, not zebras. And that's really how doctors are trained. They're trained to pattern recognition and finding the most likely explanation for things. And even in today's world, doctors are very specialized, and they really just want to treat maybe one part of your body or one aspect of it. And I think we know that with EDS, it becomes a complex, multifactorial type treatment plan, and sometimes that requires multiple specialties as well. The way I practice is I try not to be thinking horses so much as the zebra mentality. I'll have you quick slide again for me. A couple other pictures that maybe some of you could identify with. Zebras trapped in a human body. Keep calm and stretching on some issues with my tissues, and we'll talk about stretchy tissues in a little bit. I'll have you put a slide again for me. So just kind of a broad overview. Ehlers-Danlos syndrome is it's a group of relatively rare genetic disorders. Seems to be becoming a little less rare as more people are finding out about what's going on with their body. And so it's a genetic disorder of connective tissue characterized by skin hyperextensibility, joint hypermobility, and tissue fragility. And this not only applies to muscles, tendons, ligaments, this can also apply to blood vessels, digestive tracts, anything where collagen is found in the body. And collagen makes up all of our soft tissue and our bones as well. So overall frequency of EDS is 1 in 5,000, and there are subtypes. There are more common types and more rare types. Some of the more rare types may be more in the 1 to 20, 1 to 50,000. What I mainly deal with is what was previously known as type 3, which is now called hypermobility type, and it's likely up to 1 in 5,000 frequency, and based on the research that I was reading on this. I put a slide in for me. So, classification of EDS has changed in recent years. It used to be classified in subtypes, numbers 1 through 7, 7A, 7B, and 7C, and now they've broken it down into 6. They've actually put some nomenclature to it. Again, I mainly deal with hypermobility type. I have seen some people with vascular type. It's more rare, but the vast majority of my patient population who is sent for exercise intervention is the previous type 3 hypermobility type. And that's mainly what we're going to talk about today. There is some carryover from some of those subtypes. Across the entire span, we typically have joint hypermobility, tissue fragility, we have frequent dislocations of joints, a history of numerous injuries to various body parts, and the spectrum is wide. I didn't add it on here. I was going to add a slide as well to the zebra. If any of you have heard that no two snowflakes are the same, I have not experienced two patients with EDS that are quite the same. Some people tend to be very upper extremity oriented, where they'll have shoulder dislocations, a lot of problems with hands, fingers, writing, very fine motor type aspects. Some people are more in their knees, ankles, feet. It's a very wide spectrum of how the presentation takes on. I have a quick slide in here for me. Most types of EDS, the underlying pathology involves inherited changes in genes affecting the synthesis and processing of different forms of collagen. So this is a genetic condition, typically passed on from a parent, and can be passed on to a child as well. And genetically, the collagen, the type 1 collagen, that helps build stability in our soft tissue gets modified, and we end up with tissues that are very stretchy, very hypermobile, more so than they should be, putting them more at risk for injury, for tearing, for instability. And important in the structure of, they're important in the structure of many tissues, including organs, skin, tendons, ligaments, vasculature, the skeleton, and the eyes. Some points of clinical presentation, and this list could go on as well. These are some of the frequent ones that we see. Joint hypermobility, which we test with a scale that we'll talk about later. A history of multiple joint dislocations can be present. We see a lot of patella or kneecap dislocations in the history, a lot of shoulder dislocations. And sometimes I differentiate between dislocations and subluxations. So I consider like a dislocation to be a complete disassociation of a joint, so like a ball coming out of the socket in the shoulder, and sometimes has to be reduced by a physician. Sometimes the hypermobility gets so great, and you get such a good self-awareness that you can dislocate your shoulder and put it back in, and it just does it on its own. And sometimes you'll wake up and that shoulder might be out, and you just have to kind of dangle it back in, and maybe some of you experience some of that. Subluxations, now these can be felt more so as just an awareness that your joints aren't quite where they should be. Sometimes like that hip just doesn't quite feel like it's in the socket right. So you may be getting some impingement or something that would cause some discomfort there. So dislocations and subluxations. Some other symptoms that can be present: translucent skin or overly elastic skin, which can cause easy tearing of skin. Can also cause delayed healing with wounds, with surgical healing. Sometimes wounds can be slower to heal. The scar tissue can be more fragile in nature. Easy to bruise. Definitely an association of joint pain and muscular pain is present. There can be pes plantis or flat feet. We notice sometimes pectus excavatum, which is a kind of an inward sinking of the sternum and chest cavity there. We can also have a couple that aren't out here that I do see frequently: digestive issues. We'll have people with complaints of frequent constipation because that intestinal tract can stretch, and then there's just nowhere for that to go. As well as dizziness with positional changes, which sometimes can go hand in hand with a condition called POTS, which we'll talk about in a little bit as well. Go ahead and put a slide. All right, I put some questions in here that were submitted to Deb previously, so we'll try to answer those as we go, and just kind of sprinkle some question slides throughout the presentation. So one question is, how important is it to see an EDS savvy PT? I would say sometimes it's very important. So in physical therapy, we use exercise intervention, manual therapy, different balance trainings, all of which can be very effective for people with EDS to help gain some body awareness, stability in their joints, muscular strength. A lot of therapists will use stretching as a main choice of exercise intervention. If a joint hurts, we're going to stretch it. We're going to stretch it until it feels better, aggressively sometimes, which in the case of EDS can do more damage than good. Just as a rule of thumb, not always, but I would say most of the time, we do very little muscular stretching in our sessions because it typically is not a muscular flexibility issue, it's more a joint stability issue. So we focus more on the strengthening component, more on joint awareness and balance and education to help train your body better to avoid overstressing your joints. So that can be, I think that can be an important thing to see, not only a physical therapist, but also a physician, a surgeon of any discipline. They should know about that before performing any surgeries with you, because some surgeries, they'll use your own tissue to repair, like an ACL. So in the case that if you are using a hamstring graft to repair your ACL with a hamstring that's already very stretchy, I would say chances are that down the road you could have problems with the lax ACL. So a surgeon would definitely want to know those type of things. And we touched on the second one a little bit. Can a PT without knowledge of EDS cause more harm than good? I think if you're overstretching, overworking, and you name it, if you're doing things too aggressively, too much resistance, overstretching joints, overstretching muscles, they're going to probably have more pain than benefit from the PT. Precautions with people with EDS. Any exercise interventions that we do in our clinic are done in a limited range of motion. So if we know that normal range of motion in shoulder external rotation is 0 to 90 degrees, typically someone with EDS can go from 0 to 120 degrees with no problem. So we typically do not strengthen, we limit our range of motion with strengthening exercises. With any kind of exercise intervention or movement training, we're limiting how far your body's moving through those range of motion to try to help prevent overuse of those joints, overstress of the joints, and decrease how much pain and discomfort that you would have from that, and as well as trying to avoid injury. Okay, diagnosis of EDS. We use the Beighton scale is what the University of Iowa uses, their genetics department, to assess and diagnose joint hypermobility. 1 point is awarded for the ability to perform each of the 4 maneuvers in both of your arms or legs, which we'll go through the specifics in just a second. 1 point is awarded for having unusual flexible spine, and a score of at least 5 of the maximum of 9 points is used to define hypermobility in the criteria of EDS. I get the question sometimes, age of diagnosis of EDS. And so with the research that I was reading, as well as what I see in my clinic, if we look at younger people in the age of like 4 to 6, typically their musculoskeletal structures are not mature yet, and so we can't really use this as an accurate way to diagnose in that age group because they're typically really mobile at that age still. I like to see people who are a little bit more mature in their musculoskeletal systems. Sometimes in the age of 10 to 12 is when we start to see that. And sometimes with how competitive sports are these days with kids, that's when it starts to affect their bodies more too. With gymnastics is a big one that I'll see a lot of kids with. Recurrent shoulder dislocations, pain with their spine, with all the hyper-extensing they're doing with their gymnastics moves. So let's go through that lighting scale. I can put this slide there. We start with the hands. Flat-handed, I will take the patient from 0 to 90 degrees with their pinky. If that joint right there, where the pinky meets the hand, can extend beyond 90 degrees, we give that a point on 1 point for each hand. And then with all of these, I'll typically test them and say, now we don't want to do this with your body anymore. Sometimes some of these have been like party tricks that people have done before. I had a gentleman who he said he's earned a lot of free beers in bars because he was able to go down and get a beer bottle with his mouth from a standing position, and I don't know how he could do that, and so he got a lot of free drinks out of that. So I usually tell people, once we do these, once we know that the hypermobility is present, we try to avoid these hypermobile positions of your body. I'll have you slide in for me. Next we assess thumb. We approximate the thumb to the forearm on both sides. And I'll have you put the slide again for me. There's 2 more points. Hyperextension of the elbows beyond 10 degrees. So we'll hold out palms up on both arms. If that angle of the arm hyperextends beyond 10 degrees, we give the point for each elbow. And I'll have you put the slide again. Hyperextension of both knees beyond 180 degrees. And put the slide again for me. And here's the spinal component with straight legs, can be bent forward and touch the floor flat-handed. So if we're seeing scores somewhere in the 7, 8, 9 out of 9 range, we're definitely thinking in our heads, likely we're dealing with a hypermobility component. This scale is not perfect. It does not take into consider shoulders, which a lot of people with EDS have problems with. Sometimes I will just assess, I'll do a measurement, assess how far their hands overlap, and just get an idea of shoulders. But that is the Vitan scale. So the score 0 out of 9. Usually 5 is the minimal diagnosis for a positive Vitan score showing hypermobility symptom. Go ahead and put the slide there. A couple more questions that we're going to sprinkle in here. What do you do differently with EDS patients than those who don't have EDS? Talked a little bit about it already. I like to focus on, I typically will start with strengthening muscles where your limbs attach into your body. So you hear the term core strength, absolutely important for people with EDS. It's learning how to do it safely and learning how to do it so it's not going to do more harm than good. I see a lot of people doing abdominal exercises that are probably unsafe for their back. If you put someone with EDS in those exercises, they're going to do more harm than good. So we really need to kind of go back and retrain some deep muscles in the body to stabilize the spine, the pelvis, the hips, the shoulders, the scapula. And typically, if we can build some stability in those areas, forces will, I would say less force will be traveled down the limb and settle into, say, the elbow or the wrist or the fingers or the knee or the ankle. So we definitely start close to the trunk or the torso, start strengthening there, and then we look at specific issues that the patient's dealing with and go from there and strengthen those specific areas of the body as well. How does PT help when going causes more pain? A lot of people with Ehlers-Danlos syndrome do have issues with community length mobility. Walking long distances can sometimes really irritate their bodies and set them back for a couple days, sometimes longer. So, I would say energy conservation is an important thing with people with EDS, especially if you're in a phase of your EDS where daily mobility, daily activity is really cumbersome for you. I will say that if we're thinking big picture over a lifespan, people with Ehlers-Danlos syndrome have to be active, and they have to be proactive in keeping their muscles strong. And so sometimes if we're on that journey together and we're starting out and just getting to the office is difficult, I usually try to encourage the patient. I usually try to, it will get better. We just need to build a foundation of support in your body. And once we can intervene and get that done and empower you in that way, then things start to slowly get easier and easier. But sometimes it takes just 4 to 6 months for that jump start to happen. Dr. Trepane from Iowa City will tell her patients that the home exercise program that's implemented, it will take 4 to 6 months start to build that strength up to be functional for your life. So sometimes it's even beyond when I see the patient, and within 4 to 6 weeks or 4 to 8 weeks or beyond, that we see the big results. It's a lifetime journey. Should flexibility training and exercises be avoided? I would say within reason, we want to avoid hypermobile positions of your joints, and we've touched upon that. I get the question a lot about yoga, and I might even have in this presentation that gentle yoga can be a good form of exercise. A lot of traditional poses are not appropriate for people with EDS, specifically ones that are taking their spine to hypermobile positions, ones where you're weight bearing on your hands and wrists and doing planks and downward dog. Those are not appropriate for people with EDS because you're going to end up with breakdown of wrist joints, and elbows and shoulders are not going to like that very much. So strengthening is definitely the foundation of therapy. Put a slide for me. All right. Okay. Specifically on hypermobility type, affects large and small joints in the body. People tend to experience frequent joint dislocations, shoulders, patellas, the jaw joint, the temporomandibular joint will also frequently sublux, click, be painful with chewing. Can have chronic joint pain as well as myalgia, chronic joint and muscle pain. Remember, our collagen is found not only in the tendons and the ligaments, but also the muscles. So the muscles are probably getting overextended as well. Patients may develop scoliosis or premature arthritis. I always tell people with the osteoarthritis piece, this is what we're trying to avoid. If we can intervene early and start to do a little bit of education with the patient, what to avoid, then they can take the appropriate steps, avoid the activity that's going to lead to them breaking down their joints quicker. We want to avoid the development of osteoarthritis, and that is definitely one of the risk factors in EDS. Other features that we've talked about, delayed gastric emptying, sometimes irritable bowel syndrome, POTS, and frequent headaches. And I just wanted to take a second to speak on POTS. It's frequent that I see diagnoses hand in hand with Ehlers-Danlos syndrome as well as POTS, postural orthostatic tachycardia syndrome. It is basically with position changes from, say, lying down to sitting up or standing up. We see a frequent increase in heart rate, also associated with dizziness, faintness, sweating. The heart just kind of goes into overdrive with positional changes. The way that we attack that kind of an issue, and this is by recommendation from Iowa City again, is there's a protocol that I like to use for cardiovascular exercise. Again, exercise is a weapon that we use against it, but it's a very gentle approach. It's a slow, progressive plan over months that every day you're doing a little bit. And the cardiovascular exercise is typically done either sitting, lying down, non-standing positions. So we try to train that cardiovascular system in a non-standing way, as well as improving muscular tone through the legs, through the arms, which all helps venous return to the heart and to the brain. So it's when we get that blood pooling that where there's nothing to push it back up, and that's when like that heart goes into overdrive. I need some blood up here. So that's kind of how we go about attacking that. Go ahead and put a slide on. And get into the management a little bit. First point is education. I think this is the most important of anything that we do in our clinic is education. We need to be aware of what's triggering our body to feel the way it does. Education on activity selection, education on specific things to avoid, education on appropriateness of what your joints are doing that you may not even know they're doing. The nature of the disorder is there is no curative therapy for it. This is I used the word journey before. It's going to be a journey from beginning to end, and you're always going to have to continue to be in maintenance of managing your symptoms with gentle exercise, with being aware of your body, being aware of your activity selection. Another management technique is counseling regarding strategies that may help to prevent or reduce symptoms. I think groups like this are great because when you put your heads together with multiple people and what's worked with you in the past, remember we talked about there's a large spectrum to these type of things. I have my basis of knowledge. Other specialists have their basis of knowledge. You all have your basis of knowledge too, and sometimes putting your heads together, things that have worked great for you can be very helpful. So I really encourage you to keep growing this group and talking about those things. We try to adopt a mantra of live gently, treat your body gently, but keep active. And then I usually point people in the direction of the Ehlers Danlos National Foundation. They have a great website with a lot of studies, a lot of educational tools. They sometimes will list specialties that can help. And Deb has told me that you're starting to put a list together of specialties that can help this. So that's outstanding as well. And I'll talk a little bit more specifically on. We got another slide here that I didn't have in here. We talked about finding a physician who understands EDS. Again, you're putting a list together for that because it can be a multifactorial, multi-specialist type approach. So you need to have someone who can quarterback that for you and get you to the right person. Physical therapy, it's probably the mainstay of how we educate on what you should be doing with your body. Physicians, the geneticists, the rheumatologist in Des Moines will typically send physical therapy for this issue pretty regularly. Occupational therapy can be important. Sometimes specific hand issues, finger, hand, wrist issues, sometimes splinting becomes an important part of the therapy as well. So yeah, I will make the recommendation to an occupational therapist as well for specific fitting and evaluation for the appropriateness of finger and hand and wrist splints. And those can really greatly help with daily functioning of fine motor tasks. If they have not seen a geneticist yet, I will typically have them go to the doctor and tell their doctor I need to go see the genetics department at University of Iowa. They do a really great session with their patients. They go through diagnostics. They go through a lot of education. And I just think it's a really great thing they do. And they come to Johnston maybe quarterly. I'm not sure how often. Yeah. Now, I will say that the genetic counseling at the U of I is very backed up. I've heard at most over a year. So they are very busy with working with this population. Sometimes that can be expedited if you're flexible with location, times, cancellations that other people may have. But I think that's a pretty important part of it, is just getting that educational piece with them. And if they have not seen the geneticist, I'll always ask them if they've had a cardiovascular evaluation. Because with some of the EDS types, we can have issues with arteries, veins. Always education is knowledge is power. We need to check out if there's any cardiovascular issues going on, valve issues with the heart. Especially if anything is being experienced like dizziness, short fatigue, shortness of breath, those kind of things. So that's definitely a recommendation as well. All right, specific to physical therapy, preserve and protect. That is what we're aiming for. Our goals are to prevent recurrent joint dislocation. We are trying to minimize chronic joint pain. We are trying to avoid early onset of osteoarthritis. We've already touched on the educational piece, exercise intervention. We will implement a specific exercise program for each patient has their own specific needs of where in their body they need to build stability. So we tailor that to each individual patient. And we focus on high repetition, low resistance exercise. We're working, if you've ever had like a traditional gym workout, a lot of traditional gym workouts work in sets of 5 or 8 or 10, maybe 3 to 5 sets of that, trying to build muscular strength, muscular size. We're more focused on working sets of 20 to 30 to 40 with lower resistance, sometimes holding isometric contractions, holding up a joint position against a light resistance. This is how we start to build muscular tone and joint stability. We just talked about this. We talked about core strengthening a little bit, extremity strengthening, where the limbs attach into your body. Very, very important to have that stability where the limb attaches to your body so you can maintain positions out away from your body. That's where we get our functional strength, close to our body where our limbs attach. I think it's very important to have constant monitoring with your physical therapy to make sure that your joints are doing exactly what they're supposed to do and we're getting the most efficient exercise of your body. So if any of you have ever experienced physical therapy, and I worked for a company like this prior to opening my practice, where we would be juggling multiple patients. Sometimes we'd be doing the evaluation, handing a patient off to another professional who may not be quite as trained in, may not have quite the same training that we do as physical therapists. But I think that is very important to work one-on-one with a physical therapist. It's what we built the basis of our practice on, and we won't compromise on that. So with PDS, joints have to be monitored at all times to make sure that you're doing the exercises and movements appropriately. Assist patients in appropriate activity selection. I listed a couple on here, and with an asterisk next to some of them. Swimming can be good. It also can be problematic. Some people are dealing with recurrent shoulder dislocations, so an overhead stroke might not be the best idea for them, which is why we need evaluation and specific tailoring. But swimming can be a really great activity, as well as water aerobics, water walking, water jogging. Just being in a warm water pool can be effective for people that are dealing with more of the myalgia and the joint pain, especially in like the early stages or severe stages of pain. Just dealing with that, the warm water can be helpful. Tai Chi is a great form of exercise. It incorporates balance, which is important for people with PDS because often there are proprioceptive deficits or deficits in body awareness and being able to maintain balance, which is why I'll frequently hear people say, I just feel very clumsy. I'll trip all the time. I'll fall a lot. It's not a problem with leaving clutter around. It's a problem with your body knowing where it is in space, and that also goes along with PDS. Walking is a great form of a great activity selection if it's appropriate for you and your body tolerates it. Better than running, and running incorporates more pounding on concrete, so more stress through the ankles, knees, and hips. Balance training, which we talked about with Tai Chi, as well as low impact exercises such as traditional exercise I'll recommend. My brain has just gone blank. The elliptical. The elliptical is a better form of exercise than running because you're fixed to a platform the whole time, and there is not that repetitive pounding on joints. But definitely need to individualize those plans for each patient. All right, I'll have you quick play from there. Thank you. Okay, some more questions here. What would be a safe exercise program to maintain strength after PT? I will recommend that the exercises continue that we do in physical therapy, like you're taking a medication. So we don't prescribe medication in physical therapy, but we do prescribe exercises, and those exercises do become like a medication for you. So I try to tailor it there. It's something like 10 to 15 minutes a day, but you have to do it every day, like brushing your teeth, like breathing, like taking medications. And then we try to give some other ideas of good forms of exercises. Cardiovascular exercises are important as well, especially in the situations of POTS. So we try to tailor that. How do you feel about water therapy as opposed to land therapy? Both can be good. I think that both are very appropriate. Some people also don't have means to get into a warm water pool or a cold water pool, so sometimes land therapy is the only option. If, again, I steer more towards the water therapy if people are in a very difficult time where they're dealing with moderate to severe pain in their joints and muscles. But I've also had experiences with patients where the water therapy tended to do more harm than good, so the land therapy was more appropriate. So again, just that reiteration of specific tailoring to each patient. Is the proper protocol for an EDS-related injury to start exercising right away, or should ultrasound therapy be tried first and then gentle exercise later? That's a good question, and we really haven't even touched on modalities like ultrasound or electrical stimulation, which can be used to treat painful conditions, and we have those in our clinic. And they can definitely be used to help calm down tendons, ligaments, muscles. I would say that as soon as we can intervene with exercise intervention, I like to get that started as early as possible. I think people tend to define exercise in their mind sometimes as something that's painful because they've tried it before. I've exercised before. I've gone to a gym. It hurts. What we try to implement in our clinic are exercises that are not painful, but are very specific to certain muscle groups of your body. And so we try to implement that as soon as we can. But we also have modalities if needed, as well as other manual techniques, myofascial release, and muscle massage, those kind of things. So, we're getting close here. Yeah, I think these are the last two lists of questions. How long should it take for a ligament or tendon injury to heal? What's the proper protocol for PT following an injury to a tendon or ligament? That's a big question because severity often dictates some of those things. If it is like a sprain to a ligament or a tendon or a strain to a muscle, usually 4 to 6 weeks in a healthy non-EDS population is the textbook answer to that. We know that delayed healing can be an aspect of EDS that sometimes lengthens out those healing times. So and this goes for surgical protocols too, I'll always have my patients, I'll tell them, well, here's the protocol I have from your doctor. This is great, we'll follow this, but we might be on a little bit of a slower path. So 4 to 6 weeks in completely healthy, non-hypermobile population, probably more along the lines of, I'd say, 8 to 10 weeks with, there's just a couple more delayed weeks in there. Let's see. What do you know about ASTIM therapy? Is this the most effective type of PT for patients with EDS? How might it be better than traditional PT? ASTIM is, if anybody doesn't know what ASTIM is, it's a manual treatment using prefabricated tools to kind of scrape through, or it's somewhat of like a deep massage technique through and follow muscular and tendinous anatomy. I was an ASTIM credentialed therapist at my previous clinic. I still use what I call instrument-assisted soft tissue mobilization. I would say to use that on a person with EDS might be a little overly aggressive at times. If I was using it on someone with EDS, it would be I would be pulling back on my force and probably on my duration of treatment because the tissue can be more fragile. I tend to like to use more myofascial or gentle techniques to ASTIM therapy. That just tends to be probably my preference on that, but I definitely don't want to do more harm than good to a patient. So sometimes that ASTIM therapy, its whole goal is breaking up tissue, and so it can be pretty aggressive, but could be useful I think in gentle ways. Is there useful therapy for helping to stabilize the clavicle and non-injury stability? Again, with muscular anatomy, knowing specific muscle anatomy of structures that attach into the clavicle, there's definitely exercises that we can utilize to help stabilize the clavicle. Now, if there has been a previous injury, like a shoulder separation, which typically will give you something like a piano key sign, where you can take that clavicle and push it up and down, that would be more of a ligamentous overstretching, and nothing that we can do can help stabilize those ligaments that have already been overstretched. However, we can improve muscular strength around the clavicle with specific exercises. And You know, in some cases, like if I was seeing a patient with a clavicle that was presenting with major hypermobility, that piano key sign, to the point where it's getting pretty excessive, then that would probably be a referral to a shoulder specialist who I would trust to, as well as letting them know, hey, this patient also has hypermobility EDS, and they have clavicle that is very, very sloppy. So sometimes multi-specialist approach is very good. I think that is the last slide. Yeah, and so here's just a reference page of a couple references that I used for this presentation. I think information is changing rapidly. Awareness is getting greater and greater because of groups like this, as well as people just being more aware of what's going on in their body. And I think more practitioners that are aware of it, that things will be better as well. So any specific questions or individual questions that may be tied to your own issues, I'd be happy to follow up with email on those. I can have maybe Deb pass my email along to anyone here, and I'd be happy to answer